Right, I think we'll make a start. Welcome to our webinar, Managing Fatigue in Stroke. We'll be looking at the techniques and how you establish groups to support people with this aspect of living with something after a stroke. The session is going to be presented by Nicola, Ashton and also Karen Green, who are both therapists in the North Manchester community team.
Hi, okay, so my name's Nicola Ashton. I currently work in the neuro rehab team at North Manchester. I previously worked at Bolton, which was a split post between the chronic fatigue and ME service and the neuro rehab team over there. So we basically joined our ideas together from what we were doing in the chronic fatigue team in the one-to-one packs with patients, and we developed a fatigue management group. So today we're going to talk about tips and things that we do regarding fatigue and how I brought that over to North Manchester and set up a very similar fatigue management group to what we did in Bolton. So starting off, looking at the basics. So what is fatigue? So primary fatigue is related directly to a neurological condition and thinking about how that affects them post-stroke. So their lack of energy physically, how they may have cognitive fatigue and feeling this brain fog or unable to attend to information, especially in the early stages of stroke. But again, into the latter stages, they can continue to feel this. In other neurological conditions, you can get things like heat sensitivity fatigue, and we all kind of feel this short-circuiting fatigue, where if things happen from one day to the next, that we feel that our energy levels deteriorate over time. Next slide. So feeling our secondary fatigue, this can be caused by other factors. So if we have a disturbed night's sleep, or we're feeling a little anxious, or our mood is low, you've got some pain, or our pain receptors aren't working correctly due again to a stroke. Normal day-to-day anxiety and stress can also add to this secondary fatigue. We're aware of some of the medication patients take and how that has a side effect on the fatigue levels. The environment, so how busy is the environment? Is it a busy ward environment? Is it when they get home that they have spouse and children and other people around them that may make an impact on their environment? Or is it just that the wife or the husband might like to be doing noisy chores in the background? How is that affecting them? Patients obviously have more than one condition in some circumstances, so how does that affect them? And how does deconditioning through maybe being in the hospital or over time actually add to this fatigue? Their nutrition effects, and we'll come on a little bit more into the slides, but thinking about when they eat, when they drink, and how that affects them. We've all had that sluggish feeling after a meal, and just trying to get to grips with that. Infections that they are aware of or not aware of, such as maybe mild chest infections, urine infections, those type of things, and how that adds to their secondary fatigue. Next slide. So thinking about the combination of the two, we obviously take this holistic approach where we look at how they, you're all right, Sarah, next slide, please. So looking at primary and secondary fatigue together, there is some physical health things, so there are other medical conditions and how that affects them. Again, looking at psychological and grouping those together, looking at anxiety, stress, depression, and then their sleep problems of kind of either too much sleep or too little sleep and how that affects their day-to-day. Next slide.
Energy measured. When thinking about fatigue, it is important to think about the level of energy measured to complete the daily task. For example, low. Non-tiring activities, for example, are listening to the radio. Medium is tiring activities, for example, driving. High, very tiring activity, for example, is like gardening. Fatigue will affect people in a lot of different ways and when completing different activities. Next slide, please. And we complete, in the group of fatigue, we complete an activity diary, and it's how you rank your fatigue from 1 to 10. Fatigue levels and activity and the satisfaction of this. And this, for example, if you was making breakfast, how fatigued do you come? What was the value of making the breakfast? And any comments, for example, if you've got or you felt dizzy, and it's just the comments in the diary that the patients complete. Next slide, please. And this is the same as the activity diary, but it's done for a phasic diary and for cognition and difficulties with learning disabilities. It's just an easier way to complete the diary. Next slide, please.
So looking at managing energy levels and giving the ownership back to the patient. So during their one-to-one packs or during the group sessions, what we'll get them to think about is how they can manage their energy a little bit better. So we've all used those scenarios where we talk about the energy battery, and if you do this task, how much energy will you use? So it's getting them to think about how when they're overdoing it, their energy is higher, and that when they might pay for it later. So getting them to plan the diary throughout a day or a weekly period gives them a little bit more ownership over the task that they're choosing. We talk about not planning ahead. So sometimes things are unplanned, and you may get things that interrupt your day or your weekly routine. And then other times things like getting washed and dressed or meal preparations might be easier to plan. So we get them to find a difficult, if they're finding it difficult, to think about other things that they can do. And about how, if they felt that they were doing too little, how they can slowly increase their activity levels without feeling lethargic and being deconditioned, but not exceeding to the other side of the boundary. So we want them to feel as if they are doing their tasks that are more effective, and that they're not pushing on through each of the tasks to get to the end of what they're doing. So to think more effectively, that could they stop a task halfway through and come back to it later on, or is there things that they need to do in like bigger chunks, and how they can put smaller, less kind of energy taxing exercises either side. Next slide. So we talk to them about the battery of energy and how we can supply things to your energy source, such as food, fun, relaxation, and that sense of achievement is enough sometimes just to give them that little boost. Our demands to our energy are as usual. We have stress, there is housework, there is things that we feel we have to do, and things like paperwork, filling in documents, those type of things can be really taxing to a person, and they may find that their energy levels sap quite quickly. So what we want them to think about is how they might change this, or do things slightly different to get a balance between this supply and the demand of their energy levels. Next slide. So this is my friend, and this is one of the things that I use quite a lot. So I will get them to think about how they're feeling when they say that their fatigue affects them. And fatigue is very unique to people. Some people feel that maybe their left side, if that's their weaker side, is more heavy. They, people talk about walking through mud. They might feel that they're dragging that leg a little bit more, or that the hand is a bit more uncoordinated, and that's very specific to that person rather than generalized. So we get them to think about how they feel, how it affects them, how it affects their social life. So is that the first thing that they say no to going out and socializing, and how is their mood with that? Next slide. So another thing that I get them to do is think about their symptoms and how that might change. So if in the morning they was waking up and they felt quite well in themselves physically, but then as they've done a few activities and fatigue starts to affect them, do they have any physical changes? Also, how is their mood and their anxiety and their psychological well-being? Does that change throughout the day or throughout the time? And can they see that when the fatigue hits, that is different? So from a social aspect, some people might find that the beginning of the week is better for them, but they find this burnout towards the end of the week, or that over weekend they feel that they have more time to socialise if there is something more that they do during the week. So getting them to think about when is best for them over an activity week, and where they want to fit in social activities. Next slide.
The effects of adrenaline on the body. This can be like blurred vision, dry mouth, breathlessness, heart beats faster, tummy feels like funny and butterflies, tension, aches and pains in the muscles, shakes and pins and needles. And one thing we do is teach the group that about the effects of adrenaline, and it is normal to feel that way. Next slide, please.
Okay, so all these activities that we do during the week, and if you start to write them down, we start to realise what a variety of things that we're doing, and get them to think about what that does for them. So an example for this might be driving, and this is one that comes up quite often. So for me, driving might be more of a physical thing, so the opening a car door, the getting in and out of a car, putting the seatbelt on, and what I would need to do to reach from my shoulder down to my hip and put the seatbelt in. Is it the manoeuvre of kind of using the car and the steering wheel where it's placed? Or is it more the cognitive side? Is it the planning where the route that I'm going to take? Is it noticing and looking at traffic lights, oncoming kind of cars, people walking around? So what type of activity would I class it as? So we get people to think about their activities that they're doing and think, is it more physically taxing to them, or do they find it more of a cognitive burning task? And get them to group them into these 4 sections. Again, thinking about an emotional well-being, what they do, what they enjoy, and then from a social aspect. That might be talking on social media, that might be talking on the phone. And again, using phone calls, and as an example, some people find that that's very cognitively draining if they've got speech difficulties or they have any hearing difficulties. A phone call to them might mean that their energy levels quickly deteriorate after that activity. So they have to plan that into their day and when they feel that they're at their optimum. Next slide.
Budgeting energy areas to consider when completing an activity, and it's delegation. Can we ask somebody else to do the activity? And pacing, spreading an activity and rest periods, for example, going for a walk, just resting in between and not going so far the first time, and grading, increasing the distance from walking, and saving energy for things that you want or you need to do, and organisation, keeping items within reach. And we have like a toolbox for budgeting energy and making sure that you're using this. Next slide, please. And examples of poor energy. And it's overdoing it when energy is high because you pay for that later. So maybe say you go for that walk or you go shopping and you overdo it, you're paying for that later, you'll be tired then for the rest of the day and feeling as if you don't have to push yourself to finish the task all in one go. And doing too little and feeling lethargic. Not matching activities to energy levels. And not planning ahead. And finding it difficult to ask others to do things. Next slide, please. And this is the boom and bust pattern. And it's like saying you've got an activity to do, have a really good day, so you just go and do that activity, and then the next day you have a bad day because it might set you back for 2 days, and you fatigue that you won't be able to do anything for the next 2 days. So it's just like pacing yourself and saving energy for the next day, not doing everything at once. Next slide, please.
So one thing we talk about is about breaking that activity cycle. So I know most people feel it hard to stop halfway through a task. So an example of this that often comes up where it's been a nice sunny day and people go out into the garden and they feel, oh, I'll just do a little bit of tinkering and we'll start the gardening. And they've soon started that they will do one section and they set off with their tools, and then by the end of that section they then feel that they have to go on to the next section. And what we try and educate people to do is to think about their activity and how they can stop that activity. So we often dismiss the kind of finishing of activities, closing things down, putting items away, how we're going to kind of stop the activity halfway. I once went to see a patient who had started the garden, and she said, I've only cut half the garden because I knew you'd tell me to stop, and I was getting very tired, but now and now everyone thinks that it started raining because half my grass isn't cut. And I said, well, it doesn't matter what anyone else thinks. At least next time you go out and you've got a sunny day and you cut the rest of that garden, you're not paying for it for the next few days. And it's about setting those goals that are more achievable for them, and getting them to think slightly different. Sometimes they need these excuses to stop an activity halfway, and it is quite hard to ask for help. It's something we're not quite good at as a race. You know, we decide that when we're doing things that we need to continue with that, and we don't always ask for help to finish it when we're struggling. So it's about thinking and normalizing with the patient that it's okay to ask for help, and it's okay to say that you got tired during that activity. So we talk to them about how they can break this cycle and how they can find where they're happy with and what they will do as kind of a setback. Next slide, please. So one thing I think is important that they need to look at is their sleep hygiene. So many people have different ways in which they record their sleep, or even just acknowledging what time they go to bed. So we introduced at an early stage the theories and the evidence base behind sleep hygiene, and looking at how you go from being awake into the early stages, stage 1 and 2 of sleep. And these are the stages, kind of, some people wake up at the 4, 5 o'clock in the morning scenario. They go to and from the toilet lots. They might feel that they dream. And obviously, you know, how that affects them throughout the day. We talk about stages 3 and 4 and how the deep sleep gives them the better quality of sleep. But in order to achieve that, you must feel be able to get into sleep very well, and you must be comfortable in your sleep to have this. So we talk about things like getting to sleep, and if you had any pain during the night. So with stroke patients, a lot of it is about positioning overnight, about any pain management, their neuro receptors and how they're feeling from a sensitivity point of view, and how that affects them. Next slide, please. So things like frequently waking throughout the night might mean that it impacts on how they are. Lots of people wake up too early and then struggle to get those final hours of sleep, or that they just feel that they're not refreshed when they wake up. So getting people to recognise what their sleep problem is the first stage of overcoming that. And again, just to problem solve around where they might be lay, how they're positioned, is the lighting correct in the bedroom, do they use TV, are they on the internet, what type of things are they using before going to sleep. Next slide. So we also talk about how they'll feel this lack of energy if they're waking up feeling unrefreshed, and how things can impact on their mood, anxiety, their irritability, things like frustration, and just how that makes them feel throughout the day. Again, I've touched slightly on pain, but thinking about how medications and things affect their tolerance to the actual sleep, and do they, as they become more fatigued throughout the day, are they catnapping and how that's affecting them? And also looking at poor memory and concentration. I'll come a bit more onto that later. Next slide. So thinking about how and ways that we can kind of resolve that, and getting patients to think about jotting down their thoughts before they go to sleep if they feel they've got too much rushing around their head. Thinking about relaxation techniques, so that's one thing that we do during our fatigue management groups, and our one-to-one sessions. At the end of each session, we give them a different type of relaxation technique to try out. So these range from like breathing exercises to full-on visualization. And again, we'll talk a bit more later on in the slides. The old trick is to keep trying to keep your eyes. This apparently makes you fall asleep. And the old repetitive mental exercises of maybe thinking of a letter, and then obviously thinking of a country or a phrase or something beginning with each letter of the alphabet till hopefully you fall asleep. Next slide.
Relaxation and mindfulness is what we do with the patients and all, and the do's and don'ts of relaxation. And do's, try to concentrate on yourself, your body, and what you or what is going on around you. It helps to keep your eyes closed. Get yourself as comfortable as possible before starting, either lying on the floor or sitting on the chair. Make sure your environment is very slow and gentle. Listen very carefully to the instructions. You will be told exactly what to do, and you should not have to open your eyes to check all those around you. And it's just feeling relaxed and getting comfy, and you're breathing. and don't worry, it takes time to practice to relax. And this is what we practice within the groups. Next slide, please. And we have mindfulness, and we have apps that you can get now for NHS workers or our patients. Anyone can use it, and at the moment it's free access, the NHS workers during COVID, and you can download 1 to 10 of the mindfulness and apps that are there for relaxation. And like you say, they're free to our patients for 10 days. So next slide, please. And the other thing is food and fluid intake help. In a healthy, balanced diet, eating well and often, snack in between, and don't leave it too many hours before you're eating. Avoid caffeine and sugary drinks, because at the end of the day, you won't run your car without any petrol or oil. Your body needs the fluids and the diet to help you with your fatigue. Next slide, please. How often do you eat and drink? And that's why we complete an activity diary to include food, snacks and fluids. Combining exercises with healthy, balanced diet can maximise energy levels. Large spicy meals can make fatigue worse. Caffeine and sugar, as I said before, can leave you feeling tired later. Excess weight, alcohol and smoking can also contribute to fatigue. And with the many people that come to our groups, we ask them if some of them wouldn't have ate before they come to the group. So it's just eating that and getting to write down what they eat and drink, to do their diary as well. Next slide, please.
Okay, so most of you all know my background is occupational therapy. So we talk about ways that we can try and make each activity a little bit easier for them, and think about ways that they can save some energy. So most patients who are physically well in themselves find that it's really hard that they may need a piece of equipment just to conserve energy. So we'll talk about things like using a perch stool when completing personal care tasks. And they're a bit frustrated by this sometimes, because they've worked with their OTs, physios, people on the ward, working really hard to get to the point where they're now a bit more independent with their personal care, and then stroke patients saying, you know, I finally don't need the equipment as much as I did previously. And then we come along and say, but for your fatigue levels, we want you to go back to that technique. So it's about finding where they're comfortable. Is it that when they're standing up to do activities that they're using up more energy than if they were to sit down? And therefore, if we was to save the energy in specific activities, that when we get to later on during the day, the fatigue isn't as bad. So I teach it as a way of conserving energy for later on, and try and use the equipment as the kind of the crutch or the support mechanism to allow them to conserve their energy for other activities in the day. So like Karen mentioned earlier, we get them to rate how much this is important to them. So thinking about what their activities are. And is it that because they've worked so hard that they want to continue to be in that certain task? Or is it that they want their energy levels for something that's more enjoyable, like something sociable, or reading a book where they may need some more concentration, or something later on? So again, just reinforcing how effective is the task, and can it be graded that we can improve it over time. Next slide. So our physio, sorry Karen.
How can a physio help? Tips for exercises: choose exercises you enjoy. Saving energy in the day to day activities means more energy for structured exercise. Use pace, walk exercises can be good. Set realistic goals. Minimise travelling distance. Schedule exercises when your energy levels tend to be the highest. Exercising with a friend can be fun and help to keep your motivation and levels up. Next slide, please.
So in each of the areas, I'm not going to teach you how to make SMART goals, but in each of the areas, we get them to think about goals in the SMART way, so that they can think, what is it that I want to achieve by doing this? Is it realistic, and how long will it take me to do this? So using the SMART goals kind of framework, we can get people to think about their activities that they're completing and what is it with this limited amount of energy that they've got at the moment that's the most important to them. Next slide. So looking at cognition, this is one of the many things that people report is their biggest factor on fatigue. We often hear the brain fog terminology, and that people find that processing information is really difficult for them. So thinking about our brain's ability to perceive and acknowledge information, to retain that information, remember the information before applying it where appropriate to our daily situations. These patients who have recently had strokes or are on the recovery plan or their recovery from a stroke really struggle with this. Obviously, the stroke has made a big impact on their cognition, and now they've got this additional fatigue, which is causing a problem with things like memory, learning new tasks or new strategies that we're trying to teach as a compensation. Their concentration and their attention to the information that they're being told, and maybe with some of this medical terminology, although we try to stay away from it, we do teach new things to them. So how they find that really difficult during that task. So we need to focus on the information in the task, and they will continue to feel that they have difficulty concentrating, understanding this new information, feeling overwhelmed, maybe in situations where there is more than one person in the room, or that they are maybe on the telephone with the TV on in the background. So finding these activities more difficult and how they can cope with that in that situation. Next slide, please. So some of you may be familiar with the Braintree hierarchy of cognition, and not that we're teaching them like we would teach another therapist, but to give them some awareness on where, since their stroke or their event, that they may be finding additional issues. So teaching them that attention and concentration is the first thing at the bottom of the hierarchy that is really difficult for them, because most people will say my memory has been really bad since I've had a stroke, and trying to correct and think differently with the patients about this, that it may be their concentration, thinking from a visual point of view. Any patients who sadly suffer things like hemianopia, if you are unable to see half of the world, then that's going to make a big impact on your memory and your ways of thinking. So if you can't see something, it's quite hard to see or to understand that it's still there. So actually processing the information just in your home environment might be really difficult for them. Giving them awareness that because of their visual changes, that their memory may perceive things differently for them. Information processing for people with like word finding difficulties, temporal lobe kind of areas, or frontal information processing, thinking about how that affects them on the day-to-day and how that can be down to their stroke and actual changes in the brain as well as this impact from fatigue. So thinking about as we turn up to memory, there are different ways of finding things with memory. They may never have used aids or realised that they used aids in the past. Lots of us use calendars, diaries, mobile phones, and modern technology now is forever increasing to remember things that we did previously. And things as small as a pen and paper might really help someone to be able to retain information when they're having episodes of fatigue. Next slide.
Keeping on track planner. Factors that trigger contribute to my fatigue. Factors that lessen my fatigue. Priority areas for each. How do you intend to work towards this priority? Consider possible barriers, trouble spots, and ways to handle them. Next slide, please. Managing setbacks. Setbacks do not always have a clear cause, but there are always a number of things which can contribute to one. Overdoing it, this may be a result of taking too much on. Setbacks can arise if you fail to pace yourself properly or fail to plan, prepare. Stress, be aware of things that upset you and spot the signs if you are becoming stressed. Period of illness. Follow a bout of illness, you may be more prone to setbacks. Remember to restart activities and exercise gradually by pacing yourself. Low mood, seasonal factors. Many people find there is an interaction between frame of mind and their energy levels. And just remember that everybody is different. Next slide, please.
So we talk about the importance of having a self-management plan and thinking about how we are as a person, ways that we react, things that we know when we're feeling overwhelmed, and how they can kind of come back or set their own setback plan. So we talk to patients about what could be the unpredictable clash of their energy levels. So is it that if they go out and they walk around some shops and they're tempted by other shops, is that their weakness, that they feel that they need to get everything done on one day, and therefore they may have a flare-up or a setback as a result of that. Other times we talk about things like being invited to a wedding or a family event, and that might be something that really ticks all their boxes for something that they would love to do, and how it's acceptable that they want to be able to do, but try and set back plan how they're going to manage that activity. So is it that they could plan a rest beforehand, and is that's their priority for that day or that week, and how that fills them with other bits of their energy? So is that it gives them a sense of achievement? Is it a social aspect? What part of that activity is actually going to give back to their energy levels, rather than looking at it as it's going to be a long day, I'll have to travel, it'll be quite hard for me. Trying to give them that balance between the two. So basically telling patients that it's okay to have a setback as long as they understand the management plan. And this is try and reiterate throughout our one-to-one packs or our fatigue groups that it's okay sometimes to do those extra things or do those things that they want, as long as they can get back onto the plan. I often do joke about this being a bit like being on a strict diet, where you may go to a restaurant and choose that cheeky snack or that bit of chocolate cake that you fancy, but then the next day going back to plan. And I think it's important that patients understand that it's okay to use their own energy levels, and this is about giving them the ownership to choose what their activity is and what's important to them. Next slide. So In doing this, we touch a little bit on the CBT techniques, so cognitive behavioural techniques. And I don't present to you as a CBT therapist, just more as an occupational therapist using these techniques. And sometimes when running our fatigue management classes, we've had input from the psychology assistants, which is a real benefit to our team. So looking at challenging those unhelpful thoughts. And this is just, again, about normalising that it's okay, that sometimes we think slightly with unhelpful thoughts, or we might judge ourselves. And we talk about this judge and jury. Would we be so harsh if it was a friend? And what is kind of the information behind that? Why are you choosing to use your energy in such way? And is it a big deal, or is it something that friends and family might think is acceptable? So we kind of use this judge and jury or pros and cons approach, so that they can think about their activity that they're choosing or that they do often, and is that their best use of energy. Next slide. So some of the things we discuss is about being a mind reader or interpreting other people's perspectives. Do we think black and white? Is it that we are always saying, I should have done this, or I must have done that? And sometimes our emotions do the emotional reasoning of, I will feel really guilty if I don't go to the knitting class or to attend an event. Is it that I've not washed up and it's now the second day that I've not washed up, so I'm starting to feel emotional about that? So thinking about things and then thinking about how that's affecting our lives within our delegation and that use of energy. Next slide.
How we set up a group. We find the venue, standard operating procedure, risk assessment for the room, resources, projector, computer, pen and packs, patient waiting list, register for attendance, invite letters to patients via EMIS template, outcome measures, quality of life, modified fatigue impact scale, repeat once measures after 6 weeks, patient feedback survey, audit details and report on the discharge summary. Next slide, please.
So here at North Manchester, we're often asked about what do we use as the outcome measures for the fatigue management group. So we use the outcome measure of the quality of life, and we obviously have the 8 basic side of it for stroke patients with the smiley faces. We have the 0 to 10, and we get them to think about where their fatigue level has been over the last 2 weeks. And then when we repeat at the 6th week, that then gives them some indication on where they are, so that they can realise how far they've come. Next slide. So the modified fatigue impact scale is not new. It's been around for a long time now. I personally have been using this for many years now, and it gets patients to feel how much fatigue they have had over the last 4 weeks. If we move to the next slide, I'll just show you how it breaks down. So you can break each of the information down into a physical, a cognitive, a psychosocial, element, and then it gives you a total of the score. So we get them to again do this at the beginning and then at a 6-week marker, so that they get an idea on how that's impacting on them and how some of the things that they've started to implement might be changing in their lifestyle. So for instance, if when we do the person diagram that they are mainly having cognitive problems, we may be able to add that to the score, and then at the end seeing if there is any cognitive changes and if they have improved. Now obviously there'll be some variability in every patient, but we do a review of this and we audit our results. Next slide. So I've just put on some resources which are obviously out there at the moment. MS Society have had some downtime during COVID, and that means that they've been able to develop some online resources, which is fantastic, and patients from are obviously from the MS can sign up to that, but it's also good as a therapist to maybe sit through those 6 weeks so that you can have a look at some of the information that they're given. I've quoted Sue Pemberton and Catherine Berry because that's one of the books that I've used in the past, but also I attended a 2-day course run by Sue down in London, so that was quite nice, and then just obviously the resources for the last 2 outcome measures. Now on the spectrum, there's lots of outcome measures out there, and obviously, you know, do your research when you're setting up your groups, and you can have a look at the variety. They're just 2 that we've chose at North Manchester because we're kind of scored against them at the moment. Okay, over to you for any questions.
Thank you very much, Nicola and Karen. That was really, really well delivered, and unlike our last webinar where we had the technical nightmares from hell, it all seemed to go rather well. So I'm glad we got through it. I think there are a couple of questions on the chat function. If I can encourage you to post any questions that you might have. I've got a couple. Chris, do you want to lead off with what we have?
Yeah, no problem. So obviously Sarah's got some questions if we needed, and I've got one myself. But first question that's come in the chat is from Melanie, and Melanie's just wondering if have you been able to carry out these techniques and management remotely, and if you've discovered any new technologies to support this during COVID-19.
Okay, so unfortunately at the moment North Manchester aren't able to share information via MS Teams, and we haven't quite worked out how we can have multiple patients on Accurix for us to deliver it. However, in the background we have made all the resources so that we're able to deliver it virtually, and once we can work out how we can get people safely to join to either MS Teams or Accurix, we will be rolling that out. So that's something myself and Tracy Walker has been working closely to do.
Okay, that's great. Thanks, Nicola. I know Karen Tinney just raised her hand. I don't know if Karen actually wanted to come off mute and ask a question. I know she's lowered it now, but
Hiya. Yeah, sorry, I've got another meeting that I need to nip onto in a second, but just briefly, I just wondered if we do implement some of the, you know, the negative thinking and that side of things in our neuro community team in Trafford. Do you actually discuss with the patients as well about like maybe family and relatives sort of adding their negative views and that onto the patient themselves, you know, like obviously they're struggling with the fatigue and the sat there sometimes can be, you know, day after day not contributing like they were doing before, and families can often I guess it's really hard to see when somebody is maybe fatigued more cognitively and emotionally, and families can sort of you know, say negative things like, come on, you just need to get up and do things. Do you talk about that side of things with them as well?
Yeah, so we kind of give them an opt-in throughout the sessions, especially both, well, actually in one-to-one and in the group settings, where we'll say, do you want your carer or your family member to attend the group with you, or do you want, when we're doing the one-to-one packs, we'll sometimes set the scene and say, right, this week we're going to talk about delegation. Do you want someone who is in the house either stopping you from doing things and doing everything, or you know, maybe delegating a bit too much? Do you want them present while we have this conversation? So it's an opt-in from a patient perspective, but yeah, we've often had those conversations with family and carers present so that they're aware. And I think what I've done it a couple of times where we've had care agencies there and we've talked about personal care and where they're overcompensating and doing things for them. And I guess it's the same as you would in a normal therapy treatment plan of just kind of having that discussion.
That's really good that you include families in, because I think sometimes that it not with everybody, but sometimes obviously it is quite a factor of their unhelpful you know, patterns of behavior that are sort of triggering the patient as well and making them feel a bit down on themselves, and sort of that spiral that you're talking about and that vicious circle sort of contributing to it. So that's really good. But it's you know, I've really enjoyed it, and it's good to know that some of the things we're also doing in Trafford, it's a bit more uniform and they're doing it in other places as well. So thank you so much.
My pleasure.
Okay, thanks for your question, Karen. We've got another question, Nicola, from Amit Kishore, consultant at Salford. And Amit's just said, for a clinician seeing a patient at 6-week follow-up for 20 minutes, what advice would you suggest? And are there any local referral services? Fatigue is very common and difficult to explore in that time frame.
Okay, yeah, I mean, 20 minutes is a lot for them to get through, and we appreciate that. Also, you know, patients fatigue in that 20 minutes, and it's sometimes not something that they want to openly discuss. A bit like mood, they don't just chip in, oh, and by the way, I feel depressed. So, you know, having that open conversation with them and saying, you know, if you are feeling tired and fatigued and this is affecting your day-to-day life, please get back in touch with your teams. We know, especially in stroke patients, that it's not always appropriate at the hospital stage and at the early rehab stage. Sometimes they need to get to grips with the new them, and then later on that might be the perfect opportunity for them to come back. So when we run the fatigue management groups, a lot of those patients aren't newly diagnosed strokes. They are strokes from 12 months ago or longer, where they've now realised that actually the main theme or the main problem that keeps reoccurring is their fatigue, and that's sometimes the best place for them to come back, because they've got to know the real them. So we have that open referral luckily in North Manchester, where they can come back to us at any time. And I guess that will differ from region to region vastly across the stroke network, but you know, giving them the right techniques and the ways that they can like signposts, hopefully we can do something in the future where it's accessible to everyone.
And I find also, because I do the 6-month stroke review, that they do come through at the 6 months, and that's when they're needing fatigue, and that comes up on the outcomes of the 6-month stroke review.
Yeah.
Okay, thanks, Nicola and Karen.
Chris, just to intersect there, I think it's also worth saying that that one of the reasons that we wanted to transform our community services so that they weren't just ESD based and time limited was that things like fatigue are, you know, an ongoing problem and need a community service that perhaps extends beyond the 6-week time period and is multidisciplinary and includes sort of psychological support as well, so that patients can be properly supported. So I think that's definitely a good area for demonstrating that transformation is needed, and also that every region has a 6-month review commission, because we know that about 20% of our patients still have fatigue as an unmet need after 6 months. So yeah, were there any more questions, Chris?
Yeah, there's 2 questions. One from Sarah Williams. So does the content of your one-to-one packs and group differ?
No, it doesn't really vastly differ. There is things that obviously as a group you would get an input, so they benefit more when we do things like looking at what eating and drinking habits they have. It's a bit more embarrassing if there's only you and one other person in the room saying, oh, I skipped breakfast, but I do have some snacks in the evening. And I think it helps them if they're in a group scenario where they say, oh, well, I eat loads of kind of fatty foods or chocolatey things of an evening, and then realizing in the group that that's a common thing and that's a way of getting extra energy source before they're going to bed. And it's just kind of, so in that group format there will be things and discussions that open a bit more freely, and they kind of get reinforcement from others, whereas that's quite hard in a one-to-one pack. So yeah, it's dependent on the patient. We mainly do one-to-one packs with patients who, obviously pre-COVID, but who had more cognitive difficulties or may have been aphasic, and they just require that extra time. But that isn't a thing that would rule them out from a group setting.
No.
Okay, that's great. Thank you. We've got one final question from Mel in Bolton. I know we've touched upon 6-month reviews and recognising fatigue, but she's asked how often would you measure fatigue with an outcome measure?
Okay, so that can really vary depending on the patient. So we do it at the beginning of their education. If it sometimes on a one-to-one pack, it might be too much for them to do a full week pack in 1 week, if that makes sense. So we might split that into 2 weeks depending on their education level and their cognitive ability. So you might end up 12 weeks down the line when we're doing that kind of end review. So an outcome measure is an outcome measure. You can use it as much or as little as you like. We just feel that the patients benefit from having that information back to themselves, especially the quality of life one, because it's so quick to do. How was you feeling back then? How are you feeling now? You might feel that that's something that they can do quickly. So yeah, it's entirely up to you how often you do it, but we definitely do it at the beginning and at the end of the sessions.
Okay, thank you. I know Sarah had a couple of questions. I don't know if she wants to ask them.
I think there's one more question actually, and we can probably just squeeze that in, and then we'll wrap up.
Apologies. Yes, this is the last question. Do you currently deliver a program online one-to-one? And if so, do you deliver a differently structured program? I know you've slightly touched upon that already.
Yeah, so via Accurix, we can do one-to-one packs at the moment, and we physically post it out to the patient, or you could email it to them via your nhs.net. But we're posting the pack out, and we're just doing it over Accurix because of COVID. It's just the group format that we've not set up at the moment.
Excellent. Well, I'd just like to round off the webinar then by thanking very much Nicola and Karen from the North Manchester Community Stroke team for providing a really good overview on fatigue management. I'm sure they won't mind if you wanted to get in touch with them. We've actually got a fatigue management web page, which I'll add the slides to, and we'll pop in contact details perhaps into that. And as I said, the video will be sent out to them, posted on YouTube, etc. So thank you all for joining us. We do have other webinars coming up. I think the next one's in December, and it's on managing self-harm in the community. And look forward to seeing you again. Thank you.